All right, we have liftoff. All right, good morning. This is actually an appropriate one to do today, shock lecture. We had a very nice session with practical session with IO insertion. So those of you who missed it, actually missed a very good session. It was one of the representatives from the company who happens to be a medic, but it was an excellent presentation. And remember now, before each lecture, Vancouver Fire hosts a 1-hour practical session the hour before the lecture. So, and that's open to all medics. Obviously, Vancouver Fire started, but it's open to everybody in the county, and it's really, the last 2 sessions were excellent, and so I highly recommend it. It's good to brush up on a couple of techniques. I think the rep today gave a lot of really practical ways to approach an IO. So, if you're not getting informed that this is on before every lecture. Now we're going to probably have to go to a bigger room though, but this one is available. All right, shock. Well, some definitions here. Cellular and tissue hypoxia due to either reduced oxygen delivery or increased oxygen consumption or inadequate oxygen utilization by the tissue. So in the latter, we say, what is the latter? Well, the latter would be something like cyanide poisoning, where the actual problem is that the cells cannot utilize the oxygen. Most commonly occurs in our setting with circulatory failure and therefore reduced tissue perfusion, in other words, hypotension. But shock doesn't require, hypotension is not the definition, it's one of the components of shock. Shock is initially reversible but has to be recognized early to prevent progression. Now, so undifferentiated shock, when you have a cause unclear, it could be due to heart rate, too rapid, too slow. Could be due to the volume status of the patient. And this particular thing here is shows an ultrasound of the inferior vena cava, which is one of the ways an ED doc could pick out whether the patient was adequately perfused. We haven't got to the point yet, and I say yet, probably not in my lifetime, but sometime where we will have ultrasounds for the medics in the field. It could be obstructive causes. Obstructive cause would be something like a left ventricular end-diastolic volume problem, like a cardiac tamponade, or tension pneumothorax, so there's no fluid getting to the heart. You think that's a volume problem, but it's not. Volume's okay. It's just it's not getting to the heart. Pump failure itself. Most common cause of pump failure that we get to see is acute myocardial infarction. And then distributive issues such as anaphylaxis or sepsis. So, now you don't have to memorize that because we're going to go over these anyway. So 4 types of shock: distributive, cardiogenic, hypovolemic, and obstructive. shock types are not exclusive, and many people have circulatory failure, and many people with circulatory failure have a combination of both things. They can either have a cardiogenic and a distributive shock together. So what is distributive shock? The primary characterization of distributive shock is peripheral vasodilatation. So you've got the same amount of fluid in there, but now you've got a big venous capacitance. The venous side particularly has dilated. So you have a lot more room than you have blood. Causes of distributive shock are things like sepsis or systemic inflammatory response syndrome, which is called SIRS, neurogenic derangement, anaphylaxis, drugs and toxins, and endocrine problems. Sepsis, life-threatening organ dysfunction caused by an abnormal host response to infection. It's now not regulated like it normally. Your normal response to infection is quite well established now. So, and sepsis is more common in very young or the elders. Septic shock has a mortality in the range of 40 to 50%. Now, sepsis and septic shock are not the same. Septic shock is the end point, essentially, of sepsis, and where you begin to get multi-system organ failure. Basically, the telling point of the break between sepsis and septic shock is if you require vasopressor therapy in addition to fluid replacement, and then in the ED, or the hospital, we determine you have an elevated lactate level, which indicates lactic acidosis, which is characteristic of shock. SIRS, inflammatory response that could be infectious, can also be non-infectious, because you can get it from pancreatitis, which isn't ordinarily infectious. Can be present with burns. It's an inflammatory response to release of tissue products from the burn. Hypoperfusion caused by trauma can cause SIRS, blunt and crush injuries, amniotic fluid embolus, air fat embolism, and then there's a wonderful thing called idiopathic systemic capillary leak syndrome. We're not going to diagnose that in the field. Post-successful ROSC after cardiac arrest can develop SIRS, systemic inflammatory response. Neurogenic shock, type of distributive shock again. Hypotension shocks common with severe traumatic brain injury and spinal cord injury, which happens you get a decreased systemic vascular resistance and altered vagal tone. Now, that may be a combination then of hypovolemia, because if there's blood loss associated with this or myocardial depression, then you can have hypovolemic shock on top of a distributive shock on top of cardiogenic shock. So all things can occur at the same time. Anaphylactic shock is shock due to severe IgE, immunoglobulin E, mediated allergic reactions to whatever. Insect stings are common, some foods, some drugs. Shock, bronchospasm, increased airway resistance, and the shock is due to increased vascular permeability and decreased systemic vascular resistance, having venous capacitance. Drug and toxins, Long-acting narcotics, for example, snake and insect bites can cause distributive shock. Heavy metal poisoning, including arsenic and iron, so iron overdoses, little kids who take all of mom's prenatal will have, among other things, a distributive shock picture. Infections, and then there's toxic shock syndrome, which we don't see as much anymore, but it still occurs. Then Addisonian crises, so low cortisol, usually in a person who's taking oral cortisones and then for some reason can't take it, then they go into a shock syndrome, and this is a distributive shock. It's due to lack of the stimulation of your normal endocrine system. Mixed edema, hypothyroidism can also present as a shock. Switching gears into cardiogenic shock. Pump failure gets reduced cardiac output. Causes are usually due to cardiomyopathic. So the most common thing would be an MI involving, usually has to take out about 40% of the left ventricular myocardium, at least stun it so that it's not functioning. Then the left heart cannot develop enough systolic pressure to maintain blood pressure. So an MI, though of any size whatsoever, if you have multivessel disease, so that the heart is not functioning normally anyway. So if you start out with a low ejection fraction and now you have a little MI taking out 10–15% of your heart, then you go into failure. Severe right ventricular infarction, knock out the right heart, it can't then pump blood forward into the lungs, which goes to the left heart. Severe dilated cardiomyopathies, then there's often a stunned myocardium after cardiac arrest. There's a lot of the patients we take to the cath lab after a myocardial infarction and after a cardiac arrest, and they open the vessel, stent it, and then they'll do, and then in the first 24 hours, the ejection fraction is often extremely low. They have to be maintained on, so they're cardiogenic shock from just a stunned heart, but within X amount of time, their ejection fraction improves usually. Prolonged ischemia, myocardial depression due to sepsis or neurogenic shock, and then myocarditis, infection of the myocardium. You can also get cardiogenic shock from arrhythmias. Now, the most common thing would be ventricular dysrhythm or atrial dysrhythm, i.e. Rapid ventricular response in an atrial fibrillation. So it's, or supraventricular tachycardia, and actually we have a case review of that, which is in which the heart is beating so fast it doesn't have adequate filling time. So the patient would present signs and symptoms of cardiogenic shock, including hypotension and confusion and chest pain and look like they're having an MI. They can have a mechanical problem, such as a rupture of the papillary muscle or chordae tendineae, or ventricular septal defects, or an actual rupture of the septum or ventricle after an MI. Hypovolemic shock is reduced intravascular volume. Now, there's actually reduced volume, not just extreme capacitance like there is in distributive shock. So it's reduced intravascular volume, which ends up with reduced preload, which then reduces cardiac output. Most common, among common ones, hemorrhagic shock, blood loss, blunter penetrating trauma, GI bleeding from varices and diverticula, peptic ulcers, hemorrhage postpartum, vaginal bleeding, etc. Now, non-hemorrhagic is reduced intravascular fluid loss other than blood. So, gastrointestinal losses. Keep that in mind when we get into the case reviews too. Skin losses. You lose it from excessive sweating, excessive exercise. Renal losses, kidney losses. Third spacing into body space. So people who have ascites often have reduced intravascular volume because they've been losing fluid into the abdominal fluid, which is not available to the vascular system. Then obstructive shock. Extracardiac causes of cardiac pump failure associated with poor right ventricle output. Remember, the right ventricle is a very low pressure system. Causes: pulmonary embolus, severe pulmonary hypertension. So also pulmonary or tricuspid valve stenosis, which one prevents fluid from getting into the right atrium, the other prevents fluid from, or getting into the right ventricle, the other prevents fluid from getting out of the right ventricle into the lung system. And then mechanical, which is a decreased preload rather than pump failure. Tension pneumothorax, because the increased intrathoracic pressure keeps blood from coming back to the heart. Pericardial tamponade, you exceed the pressure. All you have to do in the pericardial tamponade in the pericardium is exceed the pressure of the vena cava. Then blood can't get into the right atrium. It's squeezed. Constrictive pericarditis, same difference. Restrictive cardiomyopathy, pretty much the same difference. It's not getting blood into the right heart. And abdominal compartmentation, which is an interesting thing where you have essentially, happens generally after blunt abdominal trauma, and you get increased intra-abdominal pressure, probably from fluid extravasation, and it essentially restricts inferior vena cava flow. Now, combined shock, a couple of combined shock. Pancreatitis, primarily distributive shock, disrupted vascular permeability and peripheral vasodilatation, so drop your preload because of peripheral vasodilatation. And then there's decreased oral intake and vomiting and diarrhea, so you get hypovolemia as part of this picture as well. And then the inflammation itself, the SIRS part of this, causes cardiogenic myocardial depression, so it's cardiogenic shock. So you get all three in severe pancreatitis. Cardiomyopathy, in patients who have known cardiomyopathy, they're often taking diuretics, and they can get hypovolemic shock from too much diuretics. Too much is not a good thing. And then cardiogenic shock because they have inadequate compensatory response to their hypovolemia. So they cannot adjust either their stroke volume or because of their cardiomyopathy, or they can't increase their their heart rate. So they're stuck with both hypovolemic shock and cardiogenic shock. So we have to treat both. Severe traumatic injury, hemorrhagic shock from blood loss, distributive shock from SIRS, spinal trauma, distributive shock from autonomic dysfunction, you get peripheral vasodilatation again, and cardiogenic shock from myocardial depression. All right. We'll revisit a lot of this again too, so you don't have to frantically write it down. Okay. Shock occurs when you get cellular hypoxia, when you have tissue perfusion reduced due to decreased oxygen delivery or increased oxygen consumption or inadequate oxygen utilization by the tissue. Cellular hypoxia results in cell membrane ion pump dysfunction. Just the sound of it is bad. Intracellular edema, leakage of intracellular contents into the extracellular space. Inadequate regulation of intracellular pH. Now, if you're following all that kind of stuff, what that does is feed, there's a vicious circle here now that feeds back to decreasing oxygen delivery even more. Now, oxygen consumption can occur, and the cells that are now injured and leaking cannot adequately use the oxygen that comes to it. So it just gets worse and worse and worse. This progresses systemically. Acidosis, endothelial, the lining of the or the outside of the cell, and the outside of the interior lining of the capillaries and vessels begin to have dysfunction. You get stimulates release of more inflammatory and anti-inflammatory cascade sequences, and then you get impaired blood flow because these areas, this was leaking, there was leaking cellular contents and fluid into the extracellular parts, which also leaks into the interstitial parts, so you get edema. And edema reduces blood flow, which compounds the whole thing again, and less oxygen delivered, less junk taken away, and it becomes a vicious part of this vicious circle. Well, what determines tissue perfusion and systemic blood pressure are determined by cardiac output and systemic vascular resistance. Blood pressure equals cardiac output times systemic vascular resistance. Cardiac output is the byproduct of heart rate and stroke volume. Cardiac output equals heart rate times the stroke volume. We do it per minute then. The stroke volume is determined by preload, by your myocardial contractility, and by the afterload, how much systemic resistance you've got. Systemic resistance is governed by vessel length, blood viscosity. Thicker blood is harder to push through any tube, and vessel diameter. And vessel diameter can be also looked at as the vessel tone, because particularly an artery has the ability to get quite big. A vein only has the ability to get bigger. It doesn't really contract back on it. So it does come back, but it doesn't have much muscular contract. So it doesn't have a lot of tone. Processes that change any of those physiologic parameters result in hypotension and shock. Pre-shock. So for the stages of shock, pre-shock, early shock, if you want to call it that, but pre-shock, compensatory responses to diminished tissue perfusion. The usual thing for most is tachycardia and peripheral vasoconstriction. So if you have decreased tissue perfusion, you try to increase delivery, and you get increased delivery by increasing the heart rate and or increasing peripheral vasoconstriction to basically raise the pressure. Early management is what we try to do to prevent progression. Now, shock itself is signs and symptoms of organ dysfunction, such as symptomatic tachycardia, dyspnea, restlessness, diaphoresis, metabolic acidosis, which we don't test for in the field yet, except a good measure might be your, what does the CO2 look like? Low CO2, hyperventilation to blow off carbon dioxide, i.e. to reduce acidosis. Diabetic ketoacidosis, best example, perfect example. Hypotension, oliguria. Well, hopefully you are, except for North Country, you will not be with a patient long enough to tell whether they're peeing an adequate amount per hour. That's how we test it. It's, how much do they urinate in an hour? Cool, clammy skin. Now, end organ dysfunction is irreversible organ damage, multi-organ failure, and death. That's when you no longer can correct that continual vicious circle or cycle. Okay, some kind of shocks, specific ones. Now, the prevalence of sepsis, this is from a journal article, that sepsis seems to be either getting more common or we're just recognizing it more. I think both things probably happen because we made a lot of issue of identifying and treating sepsis recently. And also, sepsis is more common in older populations, and we're certainly getting older, some of us anyway. Analysis of, in this multi-hospital study showed that rates of septic shock went from about 13% to about 13 to 19 per 1,000 hospital admissions, although mortality in that group decreased from 55 to 51%. Now, my interpretation of that is, yes, they recognized more cases of it and they treated it better, and so they got better. Risk factors for septic shock. An intensive care unit admission. Now, that's an interesting first bullet point, because does it mean that you're more at risk for getting an infection if you go to an intensive care, or if you're recognized to be really, really, really sick, you're gonna, for whatever reason, you end up in the intensive care and then they figure out that you have sepsis. I think that's the interpretation. But bacteremia, so an infection which gets into your blood is a bacteremia. So you've got so one of the things we do to diagnose sepsis and bacteremia is to do blood cultures. So by definition, a blood culture positive for bacteria is not a good thing. That means you probably have sepsis. Advanced age, over 65. Immunosuppression, which usually is over 65, or on medications like steroids, et cetera, chronically, immunosuppressives, somebody who has AIDS. Diabetes, Obesity. Cancers. Well, you have some immunosuppression there. Community-acquired pneumonia. Oh. Pneumococcus. Strep pneumonia. Very common cause of sepsis slash septicemia, bacteremia. Previous hospitalization for sepsis. Genetic factors. Symptoms and signs of septic shock are symptoms and signs specific to an infectious source. So you think that the patient had, one of the things we required or we ask you in sepsis, do you think this is there an infection? You walk into the little old lady's nursing home and you get that strong hit of urinary tract infection as you walk in the door. Well, you think right away, probable urinary tract infection if she's not her usual self, if she's either got a fever or hypothermic, a little tachycardic, you can think, hey, this is probably sepsis due to an infection. If she's got a cough, pneumonia, if she's got the flu, which is very common right now, sepsis. Hypotension, blood pressure less than 90, MAP of less than 70. Trying to think of the two things. Temperature either greater than 38.3, which is 102, or less than 36, which is, what, 97 and a half. Heart rate greater than 90. Tachypnea, greater than 20 breaths a minute. Why? Because they're blowing off CO2 equals acidosis. Signs of end organ perfusion problems. Warm, flushed skin, decreased capillary fill, cyanosis, mottled skin, hypotension, including signs of hypotension, including altered mental status, obtundation, restlessness, oliguria, anuria. Don't stay with them till you find out. Ileus or absent bowel sounds, often end stage. Now, sepsis-related organ failure assessment is SOFA. You don't need to worry about that. QSOFA stands for quick SOFA. The SOFA thing is actually 5 different, you look at 5 organ systems and it's rated as from 1 to 4 or 5. It's sort of like a sepsis-related thing for the Glasgow Coma Scale. You don't need to know that. What we do with the quick SOFA, which indicates, doesn't indicate their sepsis, but indicates a potential for a poor outcome, which might be due to sepsis, is a respiratory rate greater than 22 a minute, altered mentation, and a systolic blood pressure less than 100. If you think there's an infection there, they've got a cough, you think that maybe they've got pneumonia. If they have 2 or more of these, the QSOFA thing says these people are really at risk, and those are the ones I'd like to see come in as a sepsis alert. Then septic shock, which is the extreme of that. They've got those things, and now they've got a blood pressure that's less than 65, or less than 90, less than 70 with a MAP of less than 65, and they have a lactate, which you don't get to test, but you require vasopressors. So if you've started, you've given them a fluid challenge, and they are not moving any place, and you have to start them on a epi-drip or a norepi-drip, that patient has, is septic shock. Patients who have the criteria for septic shock have a greater mortality rate. So 40% mortality if septic shock, 10% mortality if it's just run-of-the-mill sepsis. Acute myocardial infarction is the most common cause of cardiogenic shock and the leading cause of death in patients with an acute MI. Mortality rate approaches 50%. A lot of times with the MIs, we'll end up, when they're really low, after they'll go on basically a balloon pump assist afterwards to get them through that initial time period. It's the failure of the left or right ventricle to pump an adequate amount of blood. Left ventricular dysfunction due to an MI is usually associated with an anterior MI or an anterolateral MI. Either one. May result from an infarct, especially if they've had previous damage from a previous MI or if they have severe multi-vessel coronary disease. Mechanical complications of an MI could be mitral valve regurgitation from rupture of papillary muscle, rupture of intraventricular septum, cardiac tamponade. If you get cardiac tamponade due to a left ventricular rupture, not good. Risk factors for cardiogenic shock: older age, anterior MI, history of hypertension, diabetes, multi-vessel coronary disease, prior MIs and prior congestive heart failure, systolic blood pressure less than 120, heart rate greater than 90 beats per minute, or a left bundle branch block, which is often associated with a anterior MI. Clinical sign in cardiogenic shock, they have clinical signs of hyperperfusion with hypotension, decreased urine output, altered mental status, cold, clammy skin, respiratory distress due to pulmonary congestion. If they have severe 40% or more of their left ventricle, or if they have a left papillary, if they have papillary muscle disruption and a sudden regurgitation, they can develop classically flash pulmonary edema and cardiogenic shock. In physical exam, they'll have new or worsening hypotension, tachycardia, tachypnea. They may have distended neck veins, in particular if their right heart is not functioning well. Coolness of skin, rales if they have pulmonary edema, a gallop rhythm, or a new heart murmur on examination. New heart murmur, brand new in the setting of chest pain and signs of an MI, EKG signs of an MI. If you had a new heart murmur, I'd be very suspicious for a rupture of a chordotendinae at that point. Pulmonary embolus can cause cardiogenic shock from obstruction of the pulmonary artery or a branch, and it can be anything: thrombus, tumor, air, fat. Thrombus is anything that came from someplace else in the body. Two types. You can have hemodynamically unstable pulmonary embolus. You get hypotension, and that patient is most likely to die from obstructive shock, because obviously blood's just not getting through the pulmonary vascular system. We get hemodynamically stable pulmonary emboli all the time, however. They maintain well, they have symptoms. Pathogenesis of pulmonary embolus is from venous stasis, endothelial injury, and or hypocoagulable states. The risk factors are similar to those from for venous thromboembolism. There's a whole list of things, but previous surgery, recent surgery, particularly orthopedics, when you have someone complaining of sudden shortness of breath and maybe some chest pain and coughing up a little pink tinged blood, and you ignore the fact they have a cast on their leg, that's probably an error in your judgment. That's very, so you've got venous stasis and an orthopedic procedure, you're at risk for pulmonary embolus. Pregnancy, oral contraceptives, particularly estrogen-containing ones, malignancy of any sort. There's obesity is a risk factor, older than 65, all those usual things, inflammatory, bowel disease, severe liver disease, inherited thrombophilia, which is if anybody has a family member that had a pulmonary embolus, that person's children and maybe even yourself, other relatives should be tested to see if you're at risk for increased clotting. It's not expensive now, and it's pretty common. Most pulmonary emboli arise when they're vascular, arise from lower extremity proximal veins, so leg veins. Most thrombi develop at sites of decreased flow where there's bifurcations or valve cusps that slow down the flow. Now, when you get a pulmonary, when one of these clots breaks loose and then goes to the lung, about 10% of patients have an infarction of a portion of a partial lobe of the lung, a segment of the lung. And those people typically present with pleuritic chest pain and hemoptysis, but that's only 10%. Now, with any pulmonary embolus, you get some degree or more, depending on the size of the embolus, of abnormal gas exchange. What happens, the obstruction changes what's called the ventilation to perfusion ratio, which means that you've got oxygen coming in and carbon dioxide going out to the segments of the lung, but you have some segments of the lung that don't have any blood flow through them now. So your perfusion is altered, and the ventilation stays the same, but the perfusion is altered, and that changes your blood gas abilities there. Then you get inflammation, which results in decreased surfactant or dysfunction of the surfactant, and you get atelectasis. Portions of the lungs stick together now. The alveoli don't open. The surfactant helps to keep the alveoli open, and it sticks together. They collapse. Then, with a severe pulmonary embolus, you get cardiovascular compromise because you get decreased stroke volume and cardiac output because you don't have blood going from the right heart through the pulmonary system to the left heart. Clinical presentation of pulmonary embolus, most common thing is some degree of dyspnea. Chest pain, typically pleuritic, but that's perhaps only in 10%. Cough. Symptoms of DVT, so calf or thigh pain and swelling. So that's 44%. So if you're at all suspicious, so if I can't have a good, in the good old days, if I could not find a good reason for someone's tachypnea, I would assume that they probably had a pulmonary embolus, and you do more of an exam than you would normally. You check their legs, you ask their history, you know, look for the cast, things like that. Now, orthopnea. Orthopnea means you have some dyspnea, change of position. So when you lay down, you may be more dyspneic. Sit up, less dyspneic, kind of thing. So wheezing. Not all that wheezes is asthma or reactive airway disease. So you get some degrees of atelectasis, you get some restriction of airflow, and you get wheezes. Hemoptysis. Once again, maybe 10%. So most of the time, you're going under suspicion. Now, anyone, you know, if someone suddenly says, "Oh, I can't breathe," and you listen, and then they die, you probably have a good suspicion that pulmonary embolus, big one, the classic thing. So it's the subtle ones. It's the one that don't say, "Oh, I can't breathe," and then they die, or they don't die. And those are the ones that we have to spend some thought process and time thinking about. Okay, we're at a spot I think we could take a little break. 10. All right. Let's roll back into position here. Okay, continuing with types of shock. Hemorrhagic shock. We basically still do, well, even though they're somewhat getting away from the classifications, but classically we've had the 4 classes of hemorrhagic shock, starting with class 1, which is a volume loss of up to 15% of your total body, your total blood volume, which is but in that, even up to 15% of blood volume loss, heart rate is minimally elevated or normal. There's really no change in blood pressure. Pulse pressure may be slightly narrowed, but usually normal. And the respiratory rate stays, because most of us can tolerate a pretty, a reasonable loss of blood volume. That's about a full liter of blood. Class 2, volume loss of 15 to 30%. Heart rate goes up, respiratory rate goes up, pulse pressure goes down. Systolic blood pressure stays pretty close enough. These are compensatory mechanisms then. Class 3, hemorrhagic shock, volume loss of 30 to 40%. Then systolic blood pressure now drops under 90. Mental status change, heart rate greater than 120 and thready, respiratory rate elevated, urine output is diminished, capillary refill is delayed. Class 4, volume loss of 40%. Blood pressure way less than 90 millimeters, pulse pressure less than 25 millimeters, and heart rate greater than 120, urine output down, skin is cold, pale, capillary refill is delayed, and if they continue in a class 4 volume loss, they will get end organ damage and irreversible shock. Hemorrhagic shock managed by controlling external bleeding, direct pressure, tourniquet, wound packing, IV fluid resuscitation, only if hypotensive. The reason, if you can stop the bleeding and they're not hypotensive, you don't need to put fluids in which dilutes blood, which dilutes clotting, which is likely to make more bleeding occur, particularly from something like blunt trauma. And we do IV fluid resuscitation in a class 3 shock only until you have blood products available. Now, you can say, well, I don't have blood products available. No, you don't. I just reviewed a proposal for Seattle Medic 1 that is going to be carrying 2 units of A negative blood on each of their paramedic rigs as a trial thing. Now, I'm not sure how, when I reviewed it, I get to ask questions, so I'm not sure how often they think they're going to use this. I mean, maybe people in Seattle are, bleeding out on the street all the time. We don't have a lot of, you have to have a lot to justify the price of keeping that on board, but that would be, and this is, by the way, this is not the little blood bags. This is 2 units of whole blood, not packed cells. The military, there's one good effect of having an active military involved in things where people get hurt and bleed a lot, is that they've found out that whole blood, the good old-fashioned whole blood, is the best thing to put into somebody who's bleeding from trauma. Because you got all the clotting factors, you got all the everything that belongs in whole blood, all the plasma, all the everything, and it replaces blood, and they've got remarkably good results from. And so now the medics get to carry whole blood in, combat zones. It's a bigger, it's more stuff to carry, but it works better. I said O. O negative. Oh, I'm just a slip of the tongue. I meant O negative, not A, because O negative is the universal donor. I happen to be O negative, but I'm not going to give you my blood. Okay. And then the bottom line for hemorrhagic shock is surgical intervention, because, in trauma, in shock, the answer is the operating room. Spinal cord injury, neurogenic shock, hypotension and bradycardia due to interruption of the autonomic pathways in the spinal cord. Now, contributing factors to the shock could be hemorrhage due to the trauma, inflammation, and or hypoxia if they're not, if their lungs or if their respirations are compromised. That's another reason to get shock. Management is prevent further spinal injury, treat associated hemorrhage, try to maintain blood pressure above 85 to 90, and manage any respiratory issues. So they need fluid replacement, and they may need pressor support. Anaphylactic shock, severe, acute, potentially lethal systemic hypersensitivity multi-organ syndrome caused by release of mediators and mast cell degranulation. Big stuff. Hypersensitivity is an inappropriate immune response to an antigen. It's an overshoot. Cause of death in severe anaphylaxis is generally respiratory arrest with cardiovascular collapse. Cardiovascular-wise, the effects of anaphylaxis is myocardial ischemia, conduction defects, arrhythmias, coronary artery vasospasm, increased vascular permeability, so body fluid shifts, so you get reduced intravascular volume, tachycardia as the initial response, and then bradycardia due to sympatholytic medications, vagal stimulation, and then they may have underlying cardiovascular disease. Management of anaphylactic shock is pretty straightforward. Remove the inciting cause, if you can. Epinephrine at the earliest opportunity. Supine position with lower extremities elevated. If they're vomiting, put them semi-recumbent. Pregnant patients on the left side so that you don't have the inferior vena cava compression syndrome. Supplemental oxygen, volume resuscitation with IV fluids. Now, we do throw a few extra things in there too, but that's your basic treatment. Adrenal crisis, Addison's disease. So Addison's disease is life-threatening. Well, Addison's disease is adrenal insufficiency. Adrenal crisis is overwhelming and life-threatening adrenal insufficiency. Most common signs are hypotension, shock, loss of consciousness, dehydration, sodium and potassium imbalance, which you can't really tell. Tuck this away for remembering to the final thing here. Precipitating factors, generally speaking, most Addison's disease, most Addison's or Addisonian crises occur in people who are taking oral steroid replacement for whatever reason. Now, in severe reactive airway disease and people who we need to suppress their adrenal glands. We give them high doses of steroids on a regular basis to maintain, but what this does is turn off your body's ability to make your own steroids. The adrenal gland senses that you've got so a severe asthmatic taking 10 or 20 milligrams of prednisone a day doesn't have any normal cortisol function. They don't have any adrenal function because the adrenal gland just shuts off. It doesn't need to function. Then, if for some reason the person can't take steroids orally for a few days, they run out of cortisone. They run out of, why couldn't they take them? They're sick, they're vomiting, they're not able to take medications. They go to the hospital and they're going to go into surgery and they forget that they're supposed to be on, or no one knows they're supposed to be taking this medication. We don't miss that much anymore, but it used to be not uncommon when I was in med school that people would not check to see what other medications you were on. And then you run out, and then you have an Addisonian crisis. You don't have any stress hormones anymore, and you get hypotensive, shock, etc. So trauma, infection, other stressors can also, because you have a high need for lots of adrenal steroids during those things. Then there's a tiny, tiny subset of children who are born without normal adrenal function. And they also need to, so they're hypoadrenal, congenitally hypoadrenal. And they need to take replacement steroids. They have the same problem then, is if they get sick and they can't take the oral, they have half a day or so before they need steroids. Now, their parent should be taught how to give them a injection of steroid, but sometimes they don't. The parents are afraid of needles too. So most of the time your history will tell you that this person is going to be in an adrenal crisis, because you look at their medications and they're taking high doses of steroids. If you look at, or if the parent says, yeah, the kid doesn't have any normal adrenal function. So you suspect it in a known adrenal insufficiency with trauma, infections, other stressors, nausea, vomiting, diarrhea, anything that they can't take their normal stuff. And treatment of adrenal crisis is fluid resuscitation. We start giving them glucocorticoids, so you have Solumedrol or Decadron, either one, on board, and so start them on that. Manage if they're hypoglycemic, treat that, because they sometimes are hypoglycemic. This is a multifactorial thing. If they're hyperkalemic, you can manage that as well. If they require a pressor agent, because even with the fluids they're not coming up fast enough, then use a pressor agent. Treat shock as you find it. It's basically going to be a distributive shock. All right, from our guidelines, I'm going to teach you something a little different. You're not going to go out and do it today. You're not going to go out and I made a deal with the powers that be that we don't change your orders except twice a year. Now this is really not a change of your order, but it's going to be in a little addition. So maybe we'll add it as soon, well, even sooner than August. But this is a push dose epinephrine. And look at push dose epinephrine as a bridge drug, so that so it takes a little while to mix up an epi-drip. This can be mixed up really quickly. And so it's a bridge in that 5 minutes or so between you think, oh, gee, maybe I better start an IV. The patient's a little hypotensive, maybe I better start an epi-drip on it, where you start thinking about it. What it is a bolus dose vasopressors is the administration of a small dose of vasopressor agent, in this case it's going to be epinephrine, to patients with compromised perfusion who have a pulse. Now you give big push doses of epinephrine in cardiac arrest. They don't have a pulse. They don't have a heartbeat. And so we're using basically a milligram at a time. This will be much tinier dose. So this is a temporizing measure for transient hypotension. And so you might think, well, gee, it might be worked after. Oh, I've just got ROSC and a cardiac arrest, but he's still running a pressure of about 60. Heart's beating, I got a pulse. Maybe I can give him a little something to boost this up, because it can't get fluids in them that fast. Might try to improve this a little bit. So it's a bridge to more definitive therapy. Now it's often used in anesthesiology, particularly in anesthesiology, because they often make people hypotensive from their anesthesia, and they just give them a little kiss of a pressor agent, not necessarily epinephrine, but they use alpha agents mostly. Our vasopressor of choice will be epinephrine. Indications would be severe shock with a MAP of less than 50, or systolic blood pressure less than 60, not responding yet to fluids. It's a bridge to the drip pressors as you're mixing it. It's very, so think of it in sedation. If you give somebody a sedative and they get transiently hypotensive, think of it in post-intubation when they may be transiently hypotensive as well from your medications. Think of it, and don't do it. We don't use tiny doses of push dose in cardiac arrest. Use big doses. But post-cardiac arrest, that first 5 minutes, that might be the time to use it. Onset is a minute or less. Duration is 5 to 10 minutes. Now, here's how you mix it. You take a 10 ml syringe with 9 mils of normal saline and draw up, and then go to the 10, so 9 mils first, and then draw up another mil of epi, 1 to 10,000. So the the cardiac epi. Then each amp of that has 100 micrograms per mil of epinephrine. So the result when you do this is 10 mils of epinephrine with 10 mic per mil. So it's 100 mics in a syringe, and the dose is 1 mil or 10 micrograms every 1 to 5 minutes as needed. That's your push dose. Push, check your pressure. Push, check your pressure. This is a very low concentration, so we're not really worried about extravasation. You always do this IV or IO. If you're doing an IO, it works out real well in the humerus. So basically, it's 10 microgram. You're giving a 10 mic bolus to try to pump that pressure. In the meantime, you're mixing your IV drip. So your range with an IV drip is anything from 1 mics to 10 mics per minute anyway, usually. Now, shock treatment, hypovolemia, control external bleeding, give up to 2 liters of isotonic fluid as rapidly as possible, or until blood pressure systolic is 90. You don't want to, with a map of greater, you don't want to overshoot, because the treatment of hypovolemia, particularly from trauma, is to manage, well, if it's trauma, you don't want to you knock the clots off. You don't want to dilute any clotting factor if you can help it. So we'll settle for 90. Unless it's head injury and shock, then your blood pressure targets about 100 to 110 systolic, or a map of greater than 65. Also, remember, in head injury and shock, you try to keep your ETCO2 at about 35. Now, if you're replacing, if they're hypovolemic from trauma, hypovolemic from other fluid losses, GI fluid losses, etc., then your 2 liters of isotonic fluid, you want to stop, obviously, if they get pulmonary ralves or neck vein distension. And if they have normal mentation, that's a good sign that their blood pressure is up enough. We don't sit them up to check to see if they're orthostatically hypotensive at that point. Now, what's a fluid challenge? You say 2 liters isotonic fluid. A fluid challenge for a child is 20 mils per kilo. A fluid challenge for an adult is 20 mils per kilo. So this is basically built at a 100 kilo person, 2 liters. So that would be up to that amount. And we give it, for older people, you give less more frequently. It's easier to give them less and make sure they don't have rales than to give them more and then have to worry about how I can treat the rales now. On your orders, distributive shock, sepsis, neurogenic, see the sepsis protocol if you think this is septic, but for any form of distributive shock, you start with a fluid challenge, looking for a blood pressure of 90, MAP of greater than 60, repeat, and then norepinephrine is our pressor of choice, although epinephrine is a good fallback. So we start with norepinephrine, 4 mics per minute. If no response, increase by 4 mics per minute up to a max of 12 mics per minute with your goal of 90 millimeters or MAP of greater than 60. Now with sepsis, universal patient care protocol, maintain oxygen saturation above 95 if you can. Known or suspected infection with 2 or more, remember, SOFAs. Temperature greater than 38, respiratory rate greater than 20, heart rate greater than 100, and we've added to the SOFA, we add the CO2 because it's a good substitute for a lactate meter. So EtCO2 less than 25. So if any 2 of these things are positive and you think there's an infection, call it sepsis and call it in as a septic shock alert. Now, or sepsis alert. If 2 or more of the following and a blood pressure less than 90, that's septic shock. Call that in as a septic shock alert. I guess we don't call in as a sepsis alert. We tell them as you come in. So don't just call septic shock alert if their blood pressure is low along with the other 2 and you think it's infection. So up to 2 liters of fluid, this is distributive shock again, until they get a MAP of greater than 65 or neck vein or pulmonary rales. And they also go to, you can do norepinephrine at that dosing rate or epinephrine. If the patient is normotensive and not altered, transport not emergent. And just tell the hospital personnel that they're possible sepsis. Cardiogenic shock. Follow your dysrhythmia protocol. So treat PSVT, treat VTAC with pulses, quote, stable or unstable. So unstable you treat with sparking, stable you treat with medications. Yeah, now, it's hard to say that anyone who was in cardiogenic shock would be, quote, stable. So, give 250 to 500 cc fluid challenge. Try to maintain blood pressure greater than 90 if they're not in dysrhythmia. Repeat once. And with cardiogenic shock, we try to keep it down to about 1,000 cc, 1,000 mils. With norepinephrine, then, is your cardiogenic pressor of choice. With an alternative epinephrine, I might use epinephrine if your heart rate was low. Now, sometimes you give norepinephrine, your heart rate will rise, or your blood pressure improves, but your heart rate decreases, so your cardiac output kind of falls. And then in that case, we often will put an epinephrine drip on the patient as well to drive the heart rate. Hypoadrenal shock, Addison's crisis. Fluid challenge. Solumedrol 125 to 250, so about double your normal dose. If we run out of Solumedrol, we have orders for the dexamethasone, Decadron, 10 milligrams. And a child with Solumedrol, 2 mics or 2 milligrams per kilo. You can double that if it's not going to hurt them at all. Shock treatment in pediatric patients, general shock treatment is above, and the pediatric fluid challenge is 20 mils per kilo. We're repeating it now 1 time, so it's 40 mils per kilo. Norepinephrine dose is 0.1 mic per kilo per minute, and you can increase that up to 0.4 mics per kilo per minute. Alternative would be epinephrine, 2 to 10 mics per minute. And Solumedrol, 2 milligrams per kilo. General considerations in shock, IV lines, 2 large bore IV lines recommended. Can't always do it. Now you can always do that humeral head. And unless they've got 1 arm, you've always got 2 places to go. Tachycardia is the first sign of shock. Pulse pressure often narrows prior to fall in systolic blood pressure. Changing level of consciousness is important clue. Anaphylaxis treatment, universal patient care protocol, mild reaction per your orders, generalized itching, hives, skin signs only. Benadryl, milligram per kilo IV or IM. Severe reaction, dyspnea, wheezes, laryngospasm, angioedema, shock. BLS provider, or if their IV is delayed in critical situations. So a lot of orders around the country, even in this area, have you only giving IM epinephrine. Now, you can get IM epinephrine into somebody really quickly. So if you have severe anaphylactic shock, give them IM epi for an adult, 0.3 milligram, while you're getting ready to start your IV. Get your IV in and then start doing the rest of the stuff. So the rest of the stuff is to start an epi infusion at 2 mics per minute and increase that as needed. So fluid challenge as needed for shock. Your epinephrine is in and running. Benadryl we give IM or IV. Up to a max of 50 for an adult. Albuterol, 5 milligrams by MedNeb for wheezes. Solumedrol, 125 IV. And if they're in refractory shock, which they probably will not be because of the epinephrine drip, you could switch out to norepinephrine. Pediatrics, same difference. Just follow the change in the epinephrine guidelines. Now, a BLS provider can use an epi auto-injector per manufacturer, or we have BLS drying up 0.01 milligram per kilo IM for a pediatric case prior to the arrival of ALS if you're out in the woods. Now they have to be trained on how to do that. We've got most of the first responders trained to draw up epi. It saves you from having to buy the epi auto injector, which is now close to $500. Yeah. Pediatric and epi infusion at 2 mics per minute. Fluid challenge 20 mil per kilo, repeat times 1. Benadryl 1 milligram per kilo, IV or IM. Albuterol as needed. Solumedrol as needed. Same difference. Okay, we came out with our new version of protocol in December, January, and as we keep going through the system, we find mostly that sometimes our links don't link up. So this is this protocol is meant to use on your smart tablet, smartphone, whatever it is, and when you go to a specific, when it says go to sepsis protocol, you tap on that and it goes right to the protocol. So in our procedures, we've got some, for transcutaneous pacing, we found that there was a little glitch. It told you how to start it, but not what to do if it wasn't successful the first time. But it's actually in there, but it didn't have the link. So we now have transcutaneous pacing. We have, you can follow the energy level that we recommend to start at. It has the rate, and it has pain control. For synchronized cardioversion, initial dose we had, but we didn't have subsequent doses. So it's, the link was, so it was always there, but hiding. And also didn't have the pad placement in both places. So the pad, we prefer for synchronized cardioversion to do an AP placement. Manufacturer prefers that too. You get better luck. Okay, so those corrections are there, and when you find things that don't make sense to you, let us know. That's how we find this out. So somebody came to me at a meeting the other day and said, hey, I tried to see what the next dose, I was sparking a supraventricular tachycardia, and I didn't know what the next dose was. I said, well, it's there, but the link just wasn't there. Okay. All right, now we have some case reviews. All right. Okay, this is a cardiac arrest. Patient was found responsive to verbal stimuli laying supine on the floor of a residence. That's the ambulance description. But, so they're responsive to verbal stimuli at that moment. Per police officer, they arrived to find family performing CPR. They took over CPR and they used an AED to shock twice. Per fire, when they arrived, the second shock was being delivered and the patient began making purposeful movements like striking at them. Per the family, history now, patient had been sitting when she suddenly slumped back on the couch. She's been receiving steroid treatments for colitis. Family denied prior complaints. Patient was unable to answer questions at the scene. Patient vomited once with production of scant brown secretions. Patient had pale, warm, dry skin, normal respiratory effort with increased rate and generalized body weakness. Patient was moaning, grimacing, and moving her limbs. No other signs of distress noted. Transported code 3. Mentation continued to improve. Complained of severe chest pain and tenderness. Reported improvement following treatments. No other observed change at the destination moved to the gurney. Last seen responsive to verbal stimuli and lying semi-foulers. Okay, so police CPR, police AED, number of shocks delivered 2 altogether. And we know that it was in a VTAC or pulsus VTAC or a VFib because the machine won't shock without it. Oxygen GCS was a 10. Blood glucose 239. 12 lead showed 8 fib. This terrible rhythm strip here. It's one of the, I'm not sure if this one was printed off. It mostly shows some ischemia in the anterior and lateral leads, which can be very common after a cardiac arrest. Blood pressure is 132/87. That's pretty nice. Got some fentanyl for her pain, which improved her. Now still has her ischemic kind of changes. Pulse ox is good. So I reviewed this case, and so this was really nice work by law enforcement. 2 of them arrived at the same time in this particular area. They're dispatched if they're closest to presumed cardiac arrest. They're dispatched as well, and they beat everybody there and started doing the right things. Patient had full neuro recovery. Went home about 4 days later. She went to the cath lab and she had totally normal coronaries. She has this chronic condition and she's on, among other things, a lot of steroids, but she also, this results in her condition. She has a lot of GI problems, diarrhea, et cetera, and so she basically got hypokalemic and hypomagnesiemic, and she went into a QT prolongated torsades type situation. And when they replaced her magnesium, they gave her magnesium in the ED, and then started potassium replacement as well. And when they replaced the potassium and magnesium, she had totally normal appearing 12 leads, totally normal everything, and her echocardiogram showed a ejection fraction of 45%, which is not bad, and post cardiac arrest, that's pretty good. So she's back at home and doing perfectly normal. In retrospect, it would be, knowing her history, next time we go, if we end up having called again, it's probably a good idea to give her a little magnesium. Case 2, chest pain. Patient sitting in a recliner in a living room in care of fire. Patient states he's had what is described as substernal, non-reproducible chest pain for the past 25 minutes. States he was sitting when the pain started without any exertion. No history of chest pain, no history of previous cardiac event. Given aspirin and nitro, moved to the ambulance. Then the patient became unresponsive and VFib is seen on the monitor. He's pulseless and apneic. High performance CPR initiated at a rate of 100 with the metronome on. Now, then the defib pads are placed, AP, and monitor charged as soon as pads placed. Patient defibrillated and CPR resumed. I-gel placed, BVM ventilations are initiated at the rate of 10. Now here's an interesting thing, is that they have the Lucas there, and so at the time they placed the pads, they sat the patient up to put the AP placement of the pads on, and they slid the Lucas under him at the same time. So they sparked him laid him down and started, well, they started him on the Lucas device at that point. I'm unclear entirely about whether they did mechanical chest compressions first rather than the Lucas, or I think they did, and then they put the Lucas on.
It was a minute of CPR, put the pads on.
Yeah.
After the defibrillation, and then the Lucas device.
Okay, so that was what I was hoping the sequence was. So the Lucas, after 30 to 45 seconds after starting the Lucas, patient's eyes open and he tried to pull out his eye gel. Lucas device was paused, eye gel removed, patient's awake and yelling that his chest hurts and he's going to throw up. And indeed, he did. Transported, he's alert and oriented, stating he feels terrible. The Lucas machine was obviously stopped, although it's still ready to go. He's laying on it. He's transported. He was stable throughout that. No further cardiac dysrhythms. So here's his sequence. He gets 12 lead, he gets aspirin, he gets blood pressure, he gets a 12 lead, he gets an eye gel, defib, mechanical CPR, got some, and then his Lucas device, pulse ox is 98 when he wakes up, on Downsitron for nausea and vomiting. There's his initial thing, which looks a little torsade too, certainly. 12 lead then, or 2 lead showed left, well no, 2 lead shows the block, but stayed stable, blood pressure 110/39. And this is his post-arrest 12 lead, which shows, once again, ischemia mostly. So, patient survived well. He went to the ICU that night because his 12 lead was negative and his initial enzymes were okay, but then his second set of enzymes showed elevated troponin. Next day he goes to the cath lab. He had multi-vessel disease. So this guy's first indication of ischemic chest disease, coronary artery disease, was that he had chest pain and then had an arrest. So it's kind of lucky that he did that in front of you. And so he had a 4-vessel coronary artery bypass graft done about 2 days later, and he's alert and oriented, no chest pain except for a surgical incision. And he's going home, so he was in the hospital for his arrest and his cabbage for a total of about 6 days. So that's cardiac arrest save number 2. Mother states patient, 17-year-old male, has been sick with the flu for the past few days with heavy vomiting. He is transitioning to female, but isn't taking hormones yet. When she left for work, this AM patient was laying on the kitchen floor, but she left for work. I always just let my kids lay on the kitchen floor when I'm getting ready for work and left. But that's another story. Brother saw the patient still on the floor about 1300, and she went to work at 8 o'clock. So called the mother, then came home, and she found the same patient in the same place as he was to start with, so she called 911. They declined to know any drug intake or suicidal intent. Supine on kitchen floor, cold to touch, pale in color, and unresponsive. Well, I'd say we have some possible findings of shock. After attempts at IV and sugar checks, patient was moved to TARP and carried to the gurney, no change in condition. Multiple sugar checks attempted on 2 separate machines with errors. I still don't know what was wrong with the machines or what the problem was. Patient had no radial pulses, so blood pressure not obtained. Patient had palpable carotid pulse throughout care. Code 3. So, pulse 80, respirations 8, GCS 3, pulse ox 88, pupils dilated, non-reactive, pulse ox 93 on O2, CO2 value 15, and that's with a respiratory rate of 8. Blood glucose unable, nasal airway, IV, got some naloxone. Okay, I'll buy the naloxone on this one. You know, we don't know if it's a drug overdose. We got a decreased respiration and decreased GCS. ETCO2 again, 15, making me a little suspicious. So we got a little bit of fluids in there. What do you think wrong with this guy? He's DKA, in shock, probable. I would buy him a trip for sepsis too, but we'll see. At any rate, he's at least a DKA, severe dehydration, secondary to vomiting, and no fluid intake. We don't know how, no one reported that he was vomiting, but he had to be vomiting for a day or two. Probably the reason he's laying on the floor, he's crawling into the kitchen to try to get a drink of water. He was very acidotic, 6.9. He took a huge amount of fluids and some insulin, and he was hypokalemic, which goes with the DKA as well. Once resuscitated, he was fine. He was transitioned to, so he didn't know he was pre-diabetic or diabetic, and he said now he's a confirmed type 1 diabetic. Now, that nasal capnography probably gave us a hint that he was acidotic. So he needed a little bit more fluid. I mean, if you can't get a pulse, he definitely needed some fluid. So one IV and a little bit of fluids is not quite enough. Per friend, she had come to pick up the patient to take her to a doctor's appointment. Talked to the patient yesterday, had nothing else. Per the patient, nothing related to altered mental status. Patient was found lying in bed, altered, covered in urine and feces, and patient's skin was jaundiced. Physical exam, vitals within normal, EKG showed normal sinus rhythm, and CBG read high. Due to patient's mentation, RSI was elected and was successful. First passed ETT with assistance of an Eshman. Hyperkalemia suspected based on history. All other physical assessments are unremarkable. Past medical history, diabetes, liver disease, and kidney disease. Blood pressure is 157, pulse 85, respirations of 18. Blood glucose is high, peak T waves in V3 and V4, naloxone given, albuterol inhalation, etomidate, succinylcholine intubated, pulse ox, blood pressure 181 over 86, pulse 82, got some midazolam. There is her 12 lead. I'm not terribly impressed with peak T waves. What on this history suggests that this was hyperkalemia? got a history of liver disease, and she's jaundiced. And she says, I've got well, somebody says she's got kidney disease. GCS is 5, so she's not talking. If you thought she had peaked, if you thought she was hyperkalemic, should we have used succinylcholine to start with? Probably not, even though they did treat with the albuterol just before that, so that might have bought a little bit of time. So this one was reviewed by Dr. Fedor. Documentation leaves more questions than it answers. Overall care appears reasonable. Sounds like an ill patient, very ill patient. Unclear exactly what the indication for intubation was. AMS alone.
Are you serious? This lady was laying in a bed, covered in fecal matter, her face, her airway. She was unresponsive. She took an OPA. Question whether or not we intubate this patient? That is crazy.
Question to not whether there's enough documentation to tell us exactly. Now, you just explained a whole bunch of stuff. If you'd put that down in the narrative, then Dr. Fedor would not have made a comment about it. You want to make a comment?
That was exactly the comment. Basically, all the narrative said it was for altered mental status. The only mention of why she was intubated, what you said right there in one sentence would have been, half of this would have been missing on the feedback. But that's completely reasonable.
That doesn't question that you intubated. It questions your description of it, or why. I mean, that's what we expect you to tell us is how you saw the patient. You said the care was good, but this is the documentation.
Well, I think you're missing part of the chart then, because my documentation was spot on to what the scene was. We had to break into a 3rd-story apartment. We found this lady covered in feces, unconscious, unresponsive. I don't know what to tell you about documentation, but I can tell you if you read the fire documentation, all of that was written in there.
Well, that's not your chart, so that probably explains that part of it.
But this was a very, very, very sick lady.
Yeah, we're assuming that. It says right at the very top, this sounds like a very ill patient. Overall, the care is reasonable. The documentation leaves some questions, and it's, I can't put the fire chart and your chart together yet. So you have to provide me some say I didn't read this one to start with. So jaundice sounds like liver disease. Kidney disease is in the problem list, but no, and not in the narrative. The EKG description doesn't suggest hyperkalemia. And then he raises the issue of, if you were concerned about hypokalemia, give the patient succinylcholine. But I noticed that you did treat with albuterol before the suck, so that will ameliorate some of the effect of hyperkalemia if there is any there. And that's what the albuterol was there for, I know. And then you're probably busy, but he did note that there were only a couple sets of vital signs. But it'd be nice to have the vitals just before RSI occurs. Okay, in the hospital, this lady has an encephalopathy, probably multifactorial, including DKA, dehydration, hepatic encephalopathy. At the time this was reviewed, the patient was now oriented person, place, time, and event. Her ammonia was also elevated at admission, which is an effect of liver disease. Septic shock, 3 out of 4 criteria. Tachycardia, hypothermia. She also had leukocytosis, you wouldn't know that. She had blood cultures, both a staph and a citrobacter bacteremia, so sepsis, DKA, acute worsening of chronic kidney disease, creatinine worsening. There was not hyperkalemic though. She was ventilator-dependent respiratory failure secondary to the encephalopathy, so she was maintained on the ventilator for a while. Diabetes type 1, Graves' disease, so thyroid as well, and end-stage liver disease. So she was definitely a very sick person. Okay. The next month, Dr. Mocht will be giving the lecture, and it's on head injuries. Spinal injuries, excuse me. We've got a couple of interesting cases that will attach to that, and I will be gone during that month, so you won't have me to do the case reviews. Any other questions or issues?